Cancer Council New South Wales acknowledges the traditional custodians, both past and present, of the lands on which we live and work. Good evening, my name's Jill Mills, and tonight we will be talking about the pros and cons of breast reconstruction. So tonight, if you have any technical problems, the 1-800 number on the screen there, just call that number and the technical people will help you. And there's a passcode, there should be a passcode in the chat box as well for you to enter. So we encourage you to use the chat box tonight. Talk to each other. If you get distracted by the chat, you can watch the recording later. If you have any questions you'd like to pose to the panel, please feel free to put them up as well. So as I said, don't worry if you get distracted, you can watch it later. So if at any stage you need to speak to somebody urgently, please don't hesitate to contact a Lifeline counsellor on 13 11 14, which is available 24/7. So let's get started. Firstly, I would like to introduce our panel. I've got next to me Yvonne, Jill and Catherine. Welcome to you all.
Thank you.
And thank you for coming tonight.
Thank you.
Pleasure.
We have in the chat box Lauren, who will chat to you and answer any of your questions and hopefully keep that all under control. So say hello to her, please. So we'll start with Yvonne. She's going to tell us a bit about her story. And here we go. I'm going to pass the mouse to you.
Okay.
Over to you.
Thank you. And thanks for inviting me onto the panel.
Thank you.
So I'm going to talk a bit about my story from a boobs perspective, since that's the topic of the day. Spoiler alert, I did have a reconstruction, but my path towards it was a little bit of a long path, a long road to reconstruction. So before I get into that, I just wanted to say a couple of little disclaimers. One is this is just my experience. Like everything with breast cancer, it really varies a lot from person to person. So the decisions that I made were my decisions. They might not necessarily be the same as yours. I also wanted to say that Catherine is not my surgeon, she's my friend. But when I talk about any of the surgical consultations that I had, none of them were anything to do with Catherine. But Jill here has been my nurse and is also my friend and is absolutely brilliant. So I will be quoting Jill within this before we go on to Jill herself. And my final disclaimer is that no implants were harmed in the making of this webinar, which is my lame joke that I had to make. I was 37 when I was diagnosed with invasive breast cancer. At the time, I was a stay-at-home mum, so I was spending most of my time doing fun things and hanging out in the park, and then straight after diagnosis, I was hanging out in waiting rooms and having lots of tests, some of which I failed. But that's kind of, thrown into it at the end. My treatment began with surgery. Because my cancer was in my right breast and it couldn't be saved, I had a total mastectomy. Lumpectomy was never an option for me, and immediate reconstruction was never offered to me either. I don't know why, but it wasn't. But my main concern at the time was getting rid of the cancer, not saving my boobs. I won't say that I didn't care what happened to them, but I wanted them off. I wanted the cancer to get the hell off of me, as I put in the slide very eloquently. I didn't want them anymore. And being a larger woman on top and having lost all respect for them, I wanted them to actually both go. I requested from my surgeon that I have both removed, which was, my request was denied. Surgeons don't tend to like removing healthy tissue. And I know my surgeon was concerned that it was a panic reaction and that I would regret it later. So that was his reasons. And I think those reasons are really valid. But I hated the one-boobedness of it all. That is a new word. But you can't get away from it. When you get dressed, when you look in the mirror, you've either got you either look a bit deformed or you feel a bit deformed, or you've got a really heavy, uncomfortable prosthesis. And it was really distressing for me. And I always talk about the excellent care that I had during my whole experience, and I stand by that 100%, but that particular decision wasn't right for me. So I'm referring to my notes. So I was going to talk about the first two consultations that I had. The first consultation was really not a good experience at all. I went into it very confused, very traumatised from the whole having cancer thing. And I wasn't really quite sure what to expect. And the doctor that I saw at the time really did treat me like a body, not a person. He didn't really pay much attention to how I was feeling. He only offered me one surgical option, and then he proceeded to take photos of me. And I said yes, I agreed to it. He didn't take photos without my consent, but sort of looking back, I feel like it was really inappropriate because it was just an information gathering exercise. I hadn't agreed to go ahead with anything, and I felt really embarrassed actually by having all those photographs taken at that point in time. And I didn't have a relationship with him. It just felt wrong. The other off-putting thing about the consultation actually happened before I even saw the surgeon. I was in the waiting room, and a patient phoned up to speak to the doctor about a concern that they had. And when the receptionist hung up, they started bitching to each other about this patient, about how annoying they'd been. And I felt that you want to see a surgeon, that's the main draw card of who you're going to see, but it has to be about the whole practice, because you might be that person that has a problem, you might be the person who needs to call up, and you're entitled to good support and good post-operative care. And to be treated with respect. And I think that you need to feel really comfortable that your care from the start to the end is going to be of a standard that you're happy with. So I didn't go ahead with that doctor. The next time I had a consultation, it was during my chemo months, and I was really hating having just one boob, so I felt like I was ready for another consultation. At that consultation, I was offered either a DIEP flap procedure or the lat dorsi. I felt that after I'd gone through all those options, neither of those were right for me because I didn't want the downtime, I didn't want the recovery time. I felt that there was going to be a lot of time to recover from that. I had a 2-year-old son who was very active, and I didn't want to, well, first of all, I felt like I wouldn't be able to manage afterwards, but also I didn't want to lose more time. I was already a bit pissed off that cancer had taken me away from him when I was going through chemo and feeling sick. I didn't want to then commit to more time when I couldn't play with him. So I decided that I didn't want that. So I took a different direction, and I went back to my original surgeon and asked him if he could then just take off the other breast. And it had been a year, and I'd seen a counsellor, so he knew it wasn't a panic reaction, and he agreed to that. And it felt great. Once I made the decision to be flat and fabulous, I was actually, I was really good because I didn't have the heavy prosthesis anymore, because that really put me in a bad mood. I had my symmetry back, and as you can see in the slide, I could sleep on my stomach for the first time in years, and it felt really good. So I was happy with that. I was good for a while. No prosthesis, no bra, and if I added a little ruffle or something up the top here, then no one could tell, and I just walked about normally and all was good. But then, as treatment progressed, I, was taking some steroids, I was taking tamoxifen, and the weight gain, I gained a significant amount of weight. So even with diet and exercise, I couldn't shift it. And then one day I was in my local branch of my bank, and the bank manager asked me if I was pregnant, or actually when my baby was due. Now that's bad anyway, right? Like, I don't think anybody, I can't think of any circumstance when you're not pregnant and someone asks if you are and you think that's a compliment. But it's worse if you can't have children, and that's one of the things that cancer did to me was no more children. So that one remark just weighed really heavily and hurt a lot. But also, my stomach was bigger than my chest. I was out of proportion, so it wasn't really unreasonable for somebody to make that mistake. So I was really stuck at that time. I didn't want reconstruction, but I also didn't want the current shape that I was in, and that put me in a pretty bad headspace. So I had a chat to my husband, and we were sort of thinking about what options we might like, and then we just thought, well, maybe I'll just have some liposuction on my stomach. And it's not a reconstruction, it's a day surgery procedure, but it would put me back into proportion and make me feel a lot better about myself. So that's what we did. I am clicking. Yeah, there. So we went to see another plastic surgeon who was really highly recommended, and we talked about, wanting to do the liposuction. And during the course of that consultation, he examined me and he said, you know what, I think your skin's good enough to take an expander. And I was like, no, because I'd always been told the whole way along that because I'd had radiation, expanders weren't an option for me, and I believe that, that is generally the case. But so when he said that, I hadn't expected it. It came from left field. I freaked out a little bit, went, no, I don't want it, and just continued on booking the liposuction, which I was very, very happy with. And again, that did me for a while. I had a lot more confidence. But flat isn't flat. You've still got lumps and bumps here and there. So I was still dressing with that in mind and sort of having that conscious thought all the time. But it did do me for a while. I was happy. And then my husband had some work to do in Singapore. He was there for a few weeks. So my son and I went out and joined him and had a holiday. And for those of you who've been to Singapore, you know that it's really, really humid. And while I was there, the humidity made my lymphedema in my arm a lot worse. So I was getting dressed every morning, being uncomfortable with the compression sleeve, trying to hide the lumps and bumps. And I just kept thinking that if I only had one thing to worry about, then I'd feel a lot better. And that comment that the surgeon had made about expanders kept playing in my head. So I decided when I'd come home, I would have a conversation with him and a consultation and just see really what involved. And it turns out that I was a good candidate for that, and I had all the risks explained to me. And one of them was the expanders might not expand because of the radiation. But he said, if that's the case, then we'll just whip them out and you'll be back to where you were. And my only slight complaint was that comment was a little bit flippant, and I know he said that to reassure me that the surgery wasn't going to muck up anything else, but sort of it didn't really. When I'm on the other side, I know that it's a little bit more involved with that in terms of the patient experience and the pain and all the rest of it. But I did have people to talk these decisions over with. I had Jill. Jill has always given me really honest and balanced information, including the crippling blow that there's no such thing as an easy reconstruction. Expanders, from what I know, is a less technical, like the other operations are far more technical. So it's very easy to think that the expanders are the easy option, but not so much. And I found them particularly uncomfortable, and that's why that picture's there, because I am no longer sleeping on my stomach in comfort. I am Princess in the Pea, lying there with 100 pillows, trying to get a little bit of comfort. But that was just my experience, as I said before. Jill also told me that everyone's different, have a different pain threshold. People want different things from their reconstruction. Some people might want a more natural look. Some people that might want to have a different size. So it is very individual. But I would really encourage you, if you're going to have any of these procedures, to sort of think about what your expectations are, what you actually want as a result. And speak to other women. I think it's really, really good to be able to talk to people who know what things feel like, rather than just what the information is. And lots of us reconstruction girls will actually show you our reconstruction, if you're actually considering it rather than just being nosy. We will show you what it looks like, and I really recommend that, even if you think it might be a bit awkward looking at somebody's reconstruction. Reconstructed breasts look different to the ones that are naturally grown. I mean, the scar's a dead giveaway, but there are differences. And so, again, it's about managing your expectations and knowing what a good result looks like. And with that, I would also say, even though it's great to talk to people, I would probably avoid the online groups, because people often post their horror stories and bad experiences, rather than the good experiences. So you could really have a nice time freaking yourself out there. And the other thing that Jill said, and I hope I'm not taking anything, is in Jill's experience, a lot of the women who have delayed the reconstruction are happier could be happier, because I think for me, there was a distance between what I had and then what I was going to have. So I wasn't doing a direct comparison. This is what, this doesn't look like my breast, because by the time I had it, I'd had a few years without anything. So that was good for me. And my surgeon also told me that there's evidence that lymphedema is improved with reconstruction. And he said, funnily enough, it's not just the reconstructions that use blood vessels. It somehow seems to help all of them. And I'm not quite sure of the science behind it, and I'm not quite sure if it's a coincidence, but my lymphedema actually has been a lot more manageable since my reconstruction.
It's one of the questions that's just up there now. Does breast reconstruction affect lymphedema?
Yeah, well,
So-
I was told it actually improves things, so...
Yeah, I'm not sure why.
Anyway. It was helpful for me. Like, it hasn't gone away, but it's much more manageable and there's less fluctuations for me. Oh dear, technical hitch.
No.
Okay. So where I'm at now, so the reconstruction took about 5 minutes.
In your dreams.
5 minutes?
In your dreams.
Well, that's a mistake, obviously. It took about 5 months, including the initial surgery, the top-ups, expanding the expanders, and then switching to the permanent implants. It wasn't a fun 5 months, but that was the process that, you know, I chose and the process that took me to becoming a member of the bra-wearing community once again, when I want to.
Yeah.
They stay where they're put. I don't have to wear a bra. I am often asked whether or not I recommend having a reconstruction. And that's a difficult question. I am very pleased with mine. I'm glad I had it done, but I don't think it's right for everyone. I think, as I've been saying all along, it's a very, very individual thing and you need to do a lot of research. So my recommendation would be you take your time, you think about it, you talk to as many people as you can, talk to both professionals and people who've actually undergone a similar experience. And then with all of that information, that will help you come to a decision, I think. That's me.
So can you see that question up there, Narelle? How long was recovery after first surgery? I can't
I
read
believe
it.
you to do day-to-day
Day activities. Hi, Narelle. The first surgery for me was the most painful part of it. Having said that, they gave me one of those pumps for painkillers and I didn't know how to use it properly, so I wasn't actually getting the right pain relief. But I found it very difficult. I found that first few weeks, I think, were hard to do. Day-to-day activities, lifting up my son was not possible. I'm saying this, Catherine's looking at me, I'm saying this from my experience.
No,
and
I was
I
wondering
found
if it was more painful than the mastectomy.
it was more painful than the mastectomy. Yeah, for me it was more painful than the mastectomy, significantly. The second surgery, switching over the expanders, was fine. But that first one I did find quite painful. And that's why I've said I don't know if I can recommend it, because you do have to go through some pain and discomfort.
Yeah.
So, I mean, even if someone said, would you do it all again? I don't know what the answer would be, being completely honest. I'm really glad I did it,
Yeah.
but I don't know if I'd do that again. I don't know. Is that helpful? Is that helpful? No.
Well,
We'll see.
as you say, everybody's different.
I hope
And
that's
what
helpful, Narelle.
Yeah.
But with time, you came to your decision that you were happy with.
Sorry?
So with time, you came to the decision that you were happy with. Like it just took time, but you got to where you wanted to be.
Yeah, I'm pleased. I'm pleased with everything I did, and I know I went through a lot of processes to get there. But each process that I went through was right for me at that point in time. So I don't have any regrets about any of it, except for maybe pushing harder to have the double mastectomy right at the beginning.
Yeah.
Yeah, that's probably the good advice.
Yeah.
I'll make sure I don't click anywhere I shouldn't.
Yeah.
And so over to you, Jill.
Yeah,
I'm going to
do
pass the
now.
mouse over.
Get my notes.
So Jill's a
I
breast
have to
care
put my-
nurse,
I'm going to put my glasses on, otherwise I won't be able to see.
which are at Royal Women's Hospital.
Yes, Royal
Yes.
Hospital for Women.
Royal
Yeah.
Hospital. Okay, there you go.
Thanks. And thanks, Jill, for asking me to present today.
Thanks for coming.
Tonight.
Yes.
I'm going to...
You go on.
All right,
Yeah, I'll just get that in.
So I'm going to just go through some points that I discuss with women when they're deciding to choose reconstruction or not. And it's a very common conversation I have. So basically, firstly, it's a very individual choice. So choosing a reconstruction or not is completely your choice, and there is no right or wrong decision. So what may work for one person, as Yvonne has just said, may not work for another person, and vice versa. One of the hardest parts of a breast cancer diagnosis for some women can be the news that they will lose a breast. And many women find it difficult to come to terms with this, and it can lead to feelings of low self-esteem and psychological distress, and it can have an impact on their body image and sexuality. And for some women, the external prosthesis can be heavy or uncomfortable, like Yvonne explained earlier. Especially for larger breasted women, they can find it very uncomfortable. And for some women, you know, it can be hot in summer, although I know a lot of the new prosthesis have got lighter weight material now, so it's not as much of an issue, but it can still be hot in summer. It can often limit what clothes you wear. You know, you have to wear a higher neckline, especially in swimwear. You know, you have to wear something higher with swimwear because you don't have the same cleavage. And for a lot of women, it's just like a daily reminder of what they've been through. So even if they're years down the track from the diagnosis, having to put that prosthesis on and look in the mirror and decide what they're going to have to wear, it's a daily reminder of their cancer diagnosis. So the benefits of reconstruction. Well, depending on what type of reconstruction you have, one of the advantages may be that the appearance of the breast is very similar to before surgery. And if you choose to have an immediate reconstruction, then you know there's no period of when you're being flat-chested. So it's for a lot of women that's really, really good and important. As we've mentioned before, there's no need for an external prosthesis. So meaning the reconstruction is always going to be there, and therefore there's no need to take care of the prosthesis, you know, update it, renew it. You know, a lot of women have to get a new one every couple of years, so there's no need to do that. And they're expensive. You do get a Medicare rebate, but they can be expensive. Having a reconstruction, so lots of studies been done in this area, and having a reconstruction can help restore the feelings of femininity and self-confidence and allow the person to feel like, you know, more like their old self, really. And also studies have shown that there is no significant difference in the follow-up and detection of recurrence, which is often something that people are worried about. So. Obviously, there are limitations, otherwise it would be a no-brainer. Everybody would just go and have a reconstruction. It would be great for everybody, but, you know, there are downsides. So the reconstructed breast, as Yvonne has quite clearly said, it is going to be different to your old breast. It doesn't look the same, it doesn't feel the same. It might not be a huge difference, but it is certainly different. So there's a lot of women that think that they're just going to wake up and it's going to be the exact same as before, and that's not going to happen. It will lack the sensitivity of your natural breast. So I have had a few of my patients who have reported that they do get some sensation back, and some who have had nipple sparing reconstruction have had some sensitivity back, but it's not the same. It's not as much as the natural breast. And so it's very different. Regardless of which type of reconstruction you choose, it's going to involve a larger operation time. Plus, it may involve extra operations as well. So therefore, there's longer anaesthetic or more anaesthetics, and therefore that increases the potential risks of, you know, surgical complications. So that is to be taken into consideration. And it can be costly as well. So that's definitely something that you have to look into. And find out how much you'll be out of pocket. A lot of my work is talking to women when they have a cancer diagnosis about whether they should have the reconstruction immediately or whether they should delay it further down the track. So I would say definitely suggest be guided by your surgeon or your treatment team. As to what they think would be the best thing for you in your situation, because everybody's different. And I think that should definitely include a consultation with a plastic surgeon as well. As we're about to see from Catherine's slides, and she's got lots of lovely pictures to show you, having a reconstruction is a big decision. There's a lot of information to take on board. And some women find that they just can't process this information at the time when they're dealing with a lot of cancer information as well, and the diagnosis, and it's too much, it's overwhelming, and they really struggle. So it's really hard for a lot of women. Although this isn't a very common reason, and it shouldn't really be a reason not to have a reconstruction, it's definitely something to consider that, you know, it could potentially delay treatment, especially chemotherapy if you develop an infection, and that can happen with any surgery. You know, it's just something that you think about. It doesn't happen very often, but it potentially could happen, and something to think about. Some treatments may affect the outcome of reconstruction, and by that we mean radiotherapy. It's the plastic surgeon's nemesis, I think. And yeah, so if you know that you're going to be having post-mastectomy radiotherapy, then it's something that you really need to be aware of, that it potentially could have an effect on your cosmetic outcome, and it could compromise results. In saying that, though, having an immediate reconstruction can allow for a skin-sparing mastectomy, and that is often associated with better cosmetic outcomes. So, so a lot of women are keen to go down that track for that reason. And studies have also shown that it will assist the woman to help cope with those emotions associated with the loss of the breast. Not entirely, though, and I think it's a misconception that, you know, if you have an immediate reconstruction, that you're going to wake up and you've got a reconstructed breast and it's going to be exactly the same. You're not going to grieve the loss of your breast, and I think women still do grieve the loss of the natural breast, but it certainly does help that adjustment process. Yeah. These are some of the decision aids that I use and direct women to use for when they're trying to make decisions about reconstruction. Cancer Council Breast Reconstruction Booklet, fantastic. I use that every week, if not every day, handing it out. So it's got good practical information, lists of pros and cons, lists of questions that you can ask your surgeon, and it's really, really good book. So if you haven't had a read of that, I really advise you. I think you can get it on as a PDF online. Yeah.
And we'll be sending out resources with all the links to all these things. Yeah.
Cool. Yeah. BRECONDA website. So BRECONDA is a bit of an acronym. It stands for Breast Recon Decision Aid. And that was a study that was, I think it was over Macquarie University. They set that up as a pilot. And it looks like the Breast Cancer Network Australia has taken it on board. And so if you go into their website or click on the link there, it's like, it's got questionnaires of what's important to you, sort of like worksheets that you can work through as to what's important to you, what's not important, help you come to that decision. It's got videos of women with good and bad results, and it's a really good resource to check into. Reclaim Your Curves is a similar type thing. So it's got women showing their reconstructions and stuff like that and giving good advice. I think that's been done by one of the surgeons that we work with as well. He helped set up that website. If you have a breast care nurse where you are, I'd really advise touching base with her or him, but mostly her, I think. I think, you know, they know what's available at your hospital. They know the resources that are available to you. So I would really advise touching base with them, getting information. They may have a list, like I do, of women who have had previous reconstructions who are happy to be contacted, happy to do, as Yvonne says, show and feel and, and get them all out. Oh, we've had feels. So that they're a really good resource. And I think most places these days, with the McGrath Foundation, a lot of the rural places have access to breast care nurses as well. What have I done? Clicking. Here we go. So these are my top tips. As Yvonne said, unfortunately, I mean, in my opinion, and from what my experience is, there really isn't an easy way to reconstruct a breast. It's not a breast augmentation. It's not a boob job. And I think, you know, a lot of my patients get really annoyed by family members or friends going, oh, great, you know,
so lucky.
oh, no, you're so lucky, you're going to get a boob job and stuff. And it's just not that, yeah. So,
More than you think.
yeah, and, you know, it's different. It's very different. Having realistic expectations, and I think Yvonne touched on that, you know, going in with your eyes wide open, knowing what to expect. I think people will cope better with the outcomes if that's the case. Do your research if you can and you have time. Speak to as many people as you can. Go onto these websites, touch base with your breast care nurse. You can get a second opinion. I know that can be difficult in the rural areas because there is limited access to plastic surgeons. Often you might just have a surgeon visiting or whatever. But if you can get a second opinion, I'd really encourage you to do that. And that's pretty much it. I think I've got a final slide, which for those of you who have had tissue expanders in will know that they certainly feel like rock, but they don't rock. And and we love them, said no one. So that's me. Thank you very much.
Sorry about that, we're back again. We just had a small technical issue. So we will continue on. I was just going to say one of the questions that came up, can't remember who asked it, but we're just saying how many years after your mastectomy did you have your reconstruction, Yvonne?
About 4 years. About 4 years, because I had all that other stuff in between.
So answer that question. And there's been a lot of chat about how much does it cost. Some people saying I went as a public patient, it cost me nothing. Someone else I think said $10,000. And I think obviously it depends whether you go public or private.
Yeah.
Sure,
But
definitely.
sort of average out of pocket.
Well, it depends what type of reconstruction you get.
Yeah.
And it depends, on the surgeon as well. So it's often.
But it's important to know that there are breast reconstruction units in the public hospital, for example, at the Royal Hospital for Women at Randwick, and we do see patients there from all over the state. It's not just Sydney patients or Randwick patients. So the downside is waiting times, and you may not necessarily get the surgeon of your choice, and it can be difficult linking up with a breast surgeon to have immediate reconstructions. But nevertheless, there is a public reconstruction service, and if you can't afford $10,000 out of pocket, you can still go through the public system and get excellent care. So I think that's it. Hopefully every woman should have access to it. It can be difficult if you live in the country, but don't feel that you can't just because you can't afford to go privately.
We're seeing more and more patients come into our clinic from the country. That's good.
Okay. Thank you. So over to you, Catherine.
Thank you very much.
Thank you.
It's a pleasure to be able to speak tonight.
Thank you.
So we've already heard that breast reconstruction is about rebuilding a breast on the chest wall where the breast used to be, but also, as the guys were mentioning, you have to be realistic about what we can create. We can get a breast that looks very good, but it doesn't feel the same, and it doesn't have sensation, and it certainly doesn't function the same. So, but a lot of women find it a very positive experience, and particularly in clothes, it gives them a lot more freedom than what they used to have, but we'll get to all the different types of reconstruction. So over the last 15 to 20 years in particular, there's been a real advance in the types of options that we have to reconstruct a woman's breast. And it means that these days there usually is a breast reconstruction option for most women, no matter what their cancer is and what surgery they've had and what their age and other illnesses may be. So that's really exciting. So the questions that we have to ask ourselves as doctors and also as a patient is, firstly, does the patient really want a reconstruction? And it can, as Yvonne said, it can take time to come to that decision. Then we've got to work out what's the best timing for that reconstruction, and then finally, what type of reconstruction. I, as a surgeon, can sometimes get overwhelmed trying to explain to a patient all the different options, the disadvantages, the advantages, and it can take many consultations. And once again, as these guys have said, sometimes you need to speak to more than one surgeon because one surgeon may have a particular bias for another. So I can't imagine what it must be like for a patient trying to cope with a diagnosis of breast cancer, to also then be trying to take on board all the information about reconstruction when, as a trainee, I found difficult to sort of get my head around. So I think multiple consultations, taking your time, never be allowing yourself to be pressured one way or another, particularly by doctors, and also bring a friend along to consultations. And for example, I'm happy to be recorded during consultations, and that can be helpful as well. And as we've been saying, to reconstruct or not is an extremely personal decision. You shouldn't think that because of your age, you shouldn't have a reconstruction. You shouldn't think of that because you're not sexually active, you shouldn't have a reconstruction. You know, every woman will feel differently, and you have a right to feel however you want. And always don't feel embarrassed or that you don't deserve a reconstruction if that's what you feel about. But on the other hand, don't feel that there's something wrong with you if you feel comfortable being flat. So for every woman, you have to answer, and we've already touched on a lot of the things I'm going to say, really, how important is it to have something permanent on my chest? Can you deal with an external prosthesis? Maybe you need to trial that for a period of time. If you do want to go through breast reconstruction, you will have more days in hospital, you will have more pain, it is going to delay other things in your life. But at the end of it, it may help you feel whole again, but not necessarily. So as Jill has discussed, there are psychological and very practical advantages of a breast reconstruction. And as you can see here, just what someone can look like flat-chested, what someone can look like with a reconstruction when they're naked, and how great they can look in a bra or swimsuit. And as Jill has already touched upon, there is good evidence to suggest that breast reconstruction can help psychologically with your self-esteem and your body image. And compared to the horror of the diagnosis and the mastectomy, a lot of women have told me that even though the breast reconstruction is difficult at times with pain and discomfort and loss of time from work, and it can be difficult with juggling kids and everything else, that experience is actually very positive, because where they're heading is a positive thing rather than the cancer diagnosis is very negative. So even though it does involve more pain and time out, you are going to a place where hopefully things will be a lot more positive. So that is something to think about as well.
But even going into hospital for the procedure, you know, you feel like you're going to gain something rather than to have something taken away.
And I think compared to what you've been through, even though it can be painful, it's not so horrific. And like, I think that a lot of women just end up going for a reconstruction who have had their mastectomy, because like it's just always there. You don't have to think about what you're going to wear that day. You get up in the morning, it's there. You go to bed at night, it's still there. It's cooler and lighter than an external prosthesis. You can wear swimmers without, one woman describing to me her prosthesis floating off in the pool and being so mortified. And the balance thing, particularly if you have been big-breasted, like I had an aunt who went through breast cancer and she ended up going bilaterally flat forever because she just couldn't stand the imbalance. And that was her decision, and even though I was her niece and said, look, why don't we do a reconstruction, she was just happy with that, and I respected that. So the reason why women sometimes can't reconstruct or don't reconstruct is that they may have a particularly aggressive cancer, they may have metastases at diagnosis, or the cancer has spread and it just is not going to work out, and they're just fighting for their life and they just can't deal with a reconstruction. There are some women who really have too many other things going on with their health, and it really isn't practical for them to then put themselves under a higher risk of having a reconstruction. Unfortunately, some women don't feel they have access to surgery or actually can't access reconstructive surgery. They live in the country, they don't have resources, they don't know how to access public resources, which is always a shame. Some women just can't face any more surgery, and they can't face the thought of going into a hospital ever again. Some women have had so much time off work and it's affected their family so much they just don't want any more recovery time. There is a risk of additional complications, and some of these can be quite bad. And then particularly for implant-based reconstructions, you will need maintenance going forward depending on your lifespan, but you shouldn't think that this is, you have your reconstruction and that's it. So in terms of timing of reconstruction, as we've touched upon, there's sort of two main groups. There's the immediate, which means at the time of your mastectomy, you either start the process of reconstruction or you start and finish your reconstruction at one anaesthetic at the same time as the mastectomy, or delayed, which can be weeks, months, or even 15 years after your mastectomy. As Jill touched upon, some of the advantages of immediate breast reconstruction and that there is a potential for better cosmetic results because we can keep some of your own skin at the mastectomy site. For some women, they don't ever want to experience being flat-chested, so it's an advantage for them. And you only have one recovery time, one anaesthetic, one recovery, one time off work. The potential disadvantages is that some reconstructions make the operation 2 or 3 times as long, so that can be an issue if someone is a poor anaesthetic risk. And I think the most important thing is that trying to work out what sort of reconstruction you want, given what is going on in your life after the diagnosis of breast cancer, can be very overwhelming, and it can be difficult for women to make the right decision. So if that's the case, I don't think there's any harm in waiting, because you'll get where you want to get and you'll feel better about it. Occasionally, if someone has had an immediate reconstruction, sometimes women, once the pathology results come back, then the team decides, look, radiotherapy is indicated, and that can then lead to poorer results from the reconstruction. And that doesn't happen all the time, but it can be a disadvantage of an immediate breast reconstruction when you're not quite sure what's going to happen in terms of chemo and radiotherapy. And not all reconstructions are offered in all units and by all surgeons. So immediate breast reconstruction sometimes just isn't an option for every woman. With delayed reconstruction, there's less to deal with if you decide, look, I'm going to forget about reconstruction. I'll put it to one side. I'll deal with my cancer. I'll think about that if and when I can. So that's fine. And then you've got time to have lots of consultations with people. You don't have to feel rushed and time pressured. And I think it allows you, a lot of women want to take a bit of time to make sure that cancer's gone and that it's not coming back in that first 5-year period. The potential disadvantages, though, of waiting is that you are living without a breast, which has its pros and cons. You are, once again, having to go back into hospital and having more time off work and disruption to the family. And it's longer till you get to that end point where you're finished. You can say, I'm now like Yvonne, I've done everything. I'm now wearing a bra again, and it's all good. So we've talked about how to choose somewhere, how to get to that decision about reconstruction, immediate versus delayed, and now moving on to the different types of reconstructions that are available, which is sort of a lot. So there's roughly sort of 3 categories. We call it prosthetic, which means an implant-based reconstruction. Autologous, which means using your own tissues, or a flap, where we use a piece of tissue from your own body. And sometimes we go for a combined reconstruction. The factors that should influence you are your own wishes, like you will have done your own research and talking to other people, so you'll have an opinion, which is very important. The need for radiotherapy can influence which option is right for you. Your overall health, how many other medical problems you have, how long an anaesthetic you can tolerate. Your body size, whether you're extremely thin, whether you've had kids, whether some people who are very much overweight may not be suitable for some procedures. The breast size you want to achieve is important, and the quality of the skin and tissues you've got on your body that we can work with as reconstructive surgeons. And these things need to be pointed out to you, and that's where your reconstructive surgeon comes in. So first we'll talk about implant-based reconstruction, and usually we're talking about a silicone-type implant reconstruction. So an implant-based reconstruction in an immediate setting is depicting a skin-sparing mastectomy. So the breast oncological or breast cancer surgeon makes an incision in the breast. The breast tissue, sometimes including the nipple, sometimes not including the nipple, is removed, but the skin can be left behind. And then we can come in as the reconstructive surgeon, lift up the underlying muscle, the pec major muscle, and we pop the top half of an implant underneath that muscle so that there's an extra layer between the implant and the skin. And sometimes we cover up the lower part of the implant with another type of tissue. And then the skin is closed, and later on a nipple may be reconstructed. So that's using your own skin with an implant underneath the skin to give volume. That's an immediate implant-based reconstruction. In the delayed setting where a woman has already had a mastectomy, they have a flat chest and they just have a scar, we can't put an implant in there because there's no room. It's like, you know, having an empty balloon. You need to pump up a space to then put a prosthesis in. So what we do in that setting is we have to use an expander and then an implant. So in this diagram here, you can see that an expander is like an empty balloon. We can put an empty balloon underneath the muscle of the chest skin. So using the mastectomy scar, we open that scar, we lift up the muscle, we pop the empty balloon or expander underneath that muscle, and we close it all up and let it heal. About a month later, you then visit your reconstructive surgeon, and a small needle is placed through the skin into a special port where we can then inflate the balloon or expander with salty water or saline. And over a period of 2 to 3 months, depending on how big a woman wants to be, we slowly expand that muscle, and that slowly stretches the skin and the muscle, and actually new skin grows so that we can get to a point where we have a space big enough for the implant that we want to put in. So then about 3 months after the expander has been inserted, assuming there's been no complications, we then go and have a second operation where the mastectomy scar is reopened, the expander balloon is removed, the implant, the silicone implant, is put back in, it's sewn up, and then you recover from that operation. And after about a 4-week period, you're pretty much getting back to most of your activities apart from strenuous activities. So that's an expander 2-stage prosthetic reconstruction, which is one of the commonest reconstructions and certainly has been in the past. So the advantages, as we mentioned, is that it's relatively simple. It's a fairly short anaesthetic and recovery time. There's no extra scars anywhere on the body. It's all on the breast using your mastectomy scar. And there's no damage to any other tissues on your body. So it's all just located on this one site. The disadvantages is that it does take a long time and it's not comfortable. So you have a period of time where you're not doing all your normal exercise and activities and maybe not even your normal job. It's uncomfortable for some women having those expansions. And we can tailor the expansions to suit the woman. Sometimes we can back off a bit, sometimes we can go faster if everything's going well. And sometimes that skin just doesn't expand, particularly if there has been radiotherapy. In the overall result at the end, with an implant, if you have an implant on one side and a regular breast on the other side, this is going to be forever, even when you're 95, perky and firm, whereas the normal breast will sag and age like a normal breast does. So you can end up with some asymmetry when you're naked, but in bras and swimmers even, it can look really good. As mentioned, it does feel firmer than a regular breast. You can't get a huge breast. So if you're a woman who's like a E cup on one side with a saggy breast, you're never going to get an implant to look like that. As we mentioned as well, in a patient with radiotherapy, there is an increased risk of complications, but it's now recognised that it's not completely contraindicated as what you were told initially. So you can have an implant breast reconstruction if you've had radiotherapy, but not all women are suitable. And as I mentioned before, you can't think that once you've had your implant, it's yours forever, because if you live another 30 years, you will need a maintenance procedure to replace that implant. So moving on now from prosthetic reconstructions, we move to flap reconstructions where we're using your own tissue. And the commonest ones that are used these days are what we may have come across, a Dieppe flap or a tram flap. It's where we're using the excess skin on the tummy. So we're using a tissue, a block of tissue, which we call a flap, which is skin and fat and sometimes muscle that we take from the tummy. It's a very complex procedure. We take an artery and vein, which is like a feeding artery and vein. We move it to the chest and we join up that artery and vein to an artery and vein in the chest because we have to keep this piece of tissue alive. So the red is depicting an artery where blood flows into the flap, and the blue is where the blood goes from the flap back to the vein and back into the rest of the body. So the blood is circulating around that flap and then it's kept alive. And then we close up this defect we've made in the tummy, and you end up with a long scar on the tummy. So that's a flap procedure. It's a complex, long operation, up to 8 hours for one side. If it's a bilateral or two-sided, it can be 12 to 14 hours. And there are some pretty, it's a pretty long recovery time, but it's a very good operation. So you can see, for example, in this lady, she's got a cancer here. She's a fairly small-breasted woman. She's had a cancer here, and you can see the skin's been affected here. And because she's small-breasted and the skin, and it's very close to the nipple, she's had a mastectomy with a section of skin being removed, but she's kept some of this skin. And we've come along, we've taken some skin and fat from her tummy, and we've used the fat from the tummy to expand and create the breast mound, and a patch of skin from the tummy, and then later on she's gone on and she's had a nipple reconstruction. So if you feel this breast, it'll feel just like the other side, because essentially it's just fat. And you can see it's sort of a bit floppy like the other side as well. So overall, this gives a nice, soft feeling, natural feel to the breast. And as you can see in this lady, it can look really good. This lady here has had a mastectomy, and sometime later she's decided to have a tram flap reconstruction. So she's got fat from the tummy in association with a big skin flap. So that this underneath here, we've reconstructed the shape of the breast using fat, which is tucked up under her own skin. But then she doesn't have enough skin here to give a nice fold of the breast. So we've used the tummy skin to create the lower half of the breast. And she hasn't had her nipple reconstruction yet. But even so, even though this one, because it's not been an immediate reconstruction, she has this patch of skin, it would still feel great, and it moves and feels very natural. And is once you're over the big operation, it actually feels really comfortable for the ladies. And if you put on weight, the breast puts on weight because it's your own fat. You lose weight, it will lose weight. And this is just what the tummy can look like after surgery. So we've taken, this is the lower part of the tummy. We would use that to make 1 or 2 breasts, whatever is necessary. And afterwards, there is a really long scar. And some women would see this as a disadvantage, but some women would see it as an advantage, because after having kids, a lot of women never get rid of this stretched skin. And this is maybe a small silver lining to the whole process. If the tummy is not available for a variety of reasons, there are other options we can use. We can use the inner thigh or a tug flap to do the same sort of thing as a DIEP or a tram. And we can even use the buttock skin and fat as well, as in an S-gap flap. So there are other options. These are not very common, because often if a woman wants a tissue reconstruction, we use the tummy, but in some women we can't use the tummy. So the advantages of a flap, it's, as I said, the most natural feel and appearance, gives you a long-lasting result. So even though it's really hard work going through that procedure and that recovery, once you've got it and you're free of all your complications, it's yours forever. So it's usually just one operation, no artificial materials in your body, nothing to do later on in terms of having to change every implant. Some women might see it as a bonus tummy tuck. A tram flap or a DIEP flap does still suffer from radiotherapy changes, but not as much as an implant. The disadvantage is it's a very major complex operation. Not all reconstructive surgeons offer it. Not all women will have access to it, and not all women may want to go through that. It's a very long operating time. There's a long hospital stay, and it's a long recovery time. Like recovering from the tummy part of it can take a very long time as well. So you may be 6 months before you actually feel on top of everything again. Extra scars in different parts of your body, I've mentioned. There can be complications in those parts of the body. So the breast part may go great, but you may have a complication in the tummy. And not all women can have this. They may not have enough tummy. We don't offer it to smokers. In very overweight women, it's not suitable. Sometimes if a purely implant-based reconstruction is not suitable, and a woman doesn't want or is not suitable for a tissue transfer, where we take a piece of tissue away from the tummy and transfer it using that artery and vein surgery that I talked about, sometimes we can use what we call a pedicled flap, where we just rotate some muscle around from the back. This is a lat dorsi flap. We don't actually take it off your body and rejoin it. We just rotate it from your back to your front, and that doesn't often give a lot of volume, so we often have to use a breast implant as well. But this can be an option for some women where you're not suitable for a complete implant-based reconstruction, and you don't want, or you're not suitable for a tissue flap reconstruction. So I've probably completely overwhelmed you now, and now I'm going to add even more complexity. I'm going to talk about your other breast. So surgery on the other breast will usually be brought up with the reconstructive surgeon. Some women say, look, I want to have one normal breast. You're not touching this breast. I don't care. I just want to have one normal breast, and that's absolutely fine. But like, for example, if you have a a saggy, heavy breast on one side and you're going to have an implant on the other, you may benefit from a lift or a reduction on that size to give you more balance. And a woman may take this as an opportunity to say, look, I've always been an A cup and I'm going to have an implant on my reconstructed side. So look, you know what, I've always wanted to be a C cup, so we can pop in an implant on the other side as well if you want that. And some women may be high risk for a cancer in the other side, or may just never want to go through that risk and don't want to go through having mammograms and worry about breast cancer on the other breast, and may decide to have a prophylactic mastectomy on the non-affected side. And so there we may end up operating on that side. So as I mentioned, sometimes on the other breast we can do a lift, we can do a reduction, we can do an augmentation, or you may have a mastectomy and a full reconstruction. And that can all happen through the public hospital. Yeah. Finally, if you've got through all of that, some women want to go the extra step and have a nipple, because a breast without a nipple doesn't really look like a breast. And for some women, it's important for them to have a nipple. And some women just practice with drawing on a nipple and seeing how they feel about it before they commit to it. And so a nipple reconstruction is done usually 6 months after everything's finished. And that can be a combination of usually your own tissues to create a little nipple, plus or minus some tattooing if you want the colour. And even these days we can get great 3D tattooing, so you don't even have to have more surgery. You can just go and see a tattoo artist. So that's another option. It's not for everybody. So hopefully there's a bit of, I've got this picture that there's a bit of a road now that you can maybe see that the journey ahead is a little bit clearer. I hope it has been. I just want to reiterate that you don't have to have this done privately. It doesn't have to cost a lot of money. There are surgeons operating in the public hospital, and Jill can help with that if you live in Sydney particularly. So I hope that's been helpful.
Well, thank you. There were lots of questions and discussion coming in, and I've captured some of them. So Bree was asking, should I see a surgeon before I have radiotherapy, and should she have expanders before radiation? Kind of abbreviated question a bit.
So everyone is different. There's not one answer that suits all women. And I think if you know up front that you're having radiotherapy, it's useful to have that information. And if you've got time before you have to have your breast removed, it is good to have a consultation with a reconstructive surgeon as well as your breast surgeon. And we work as teams. The best outcomes are when you have the breast surgeon, your plastic surgeon, yourself and your family, and a breast care nurse working and discussing everything together. Yeah. So yes, if it's possible, great. Have a consultation before radiotherapy. And generally speaking, if a woman wants an implant-based reconstruction, or she has an expander in already, we will try to sort of expand that skin and pump that skin up as quickly as we can before radiotherapy, because we get a better success rate that way.
Okay. Nicole, planning on having children? Mm-hmm. So the question was sort of implants rather than own tissue, so I'm not sure exactly.
So women who haven't had children and sometimes don't have enough tummy to have their own tissue, as in a tram flap reconstruction. But you can have, whatever you do on your reconstructive side, you would have had a mastectomy, so you can't use that breast for breastfeeding. You can use your left breast for breastfeeding. If you've had a tram flap done in the past and then you fall pregnant, that is possible as well. As long as you don't fall pregnant in about the first 12 months after having a tram flap or a diet flap, you can have a pregnancy. It's like having a pregnancy after a tummy tuck. As long as it's not immediately after surgery, that's fine.
Okay. So I hope that's answered your questions.
Yeah, I hope that's what you meant.
Yeah. Do you want to just flick through to the next slide, which is the questions?
Yeah.
We're running a little bit over time, but I think there was some great questions that came through. We've just picked out a few. One that kept coming up a lot was about implants. Are they safe over these days compared to years ago? Are they better?
Yeah.
If we can just maybe touch on that.
It's a very long answer. In the past, silicone had a bad name and was taken off the market in some countries, not Australia. So it was then found that silicone does not cause connective tissue disorders, etc. So for a long time we thought, great, silicone is safe. In the last 5 to 10 years, we have become aware that there is a rare form of lymphoma that can develop in the capsule around a breast implant, which is called ALCL, anaplastic large cell lymphoma. It is becoming more common with the newer implants is thought to be, for example, a risk of about 1 in 60,000 women with a particular type of implant, up to 1 in 4,000 women with a different type of implant. So breast implants are not without risk. To put it in context, getting regular breast cancer, about 1 in 11 women. So getting a breast implant associated lymphoma is in some of the implants, which most of us are using, is about 1 in 60,000. So generally speaking, safe, extremely rare to get this type of lymphoma, but it is a definite risk of having a breast implant, and your surgeons can give you data and discuss that with you. And it is an area where there's heaps of research and being done at the moment.
Thank you. So the first one, and I think you've covered this about, you know, whether or not reconstruction surgery, times when it's not appropriate. I think you sort of touched on that.
And there can be patient factors, and then and cancer factors. So pre-existing details about a patient, their illnesses, sometimes their age, their body habitus, and then the cancer factors, the treatment of the cancer, and has always got to take priority.
Yeah, which I guess we've really kind of touched on that.
Yeah.
We might go to the single 71-year-old woman who is interested in reconstruction options, but she's too embarrassed to talk to a surgeon. She feels it's unnecessary, excessive, etc. So,
Not at
Jill,
all.
do you want to comment on that?
Yeah, no. Age shouldn't be a factor. If she's healthy, no other, illness, no other comorbidities or illnesses, then, there's no reason why she shouldn't have a reconstruction. It's, just because she's not sexually active. It's about self-esteem and, she might be. Sorry, I thought it said that she wasn't.
No, it says she's single.
Oh, she's single. All right, but she still might be sexually active.
might be.
That's right. But it's about your self-esteem. I mean, this lady might live for another 20 years. Does she want another 20 years with a prosthesis, without a reconstruction?
Being unbalanced.
Being unbalanced, so age is not a factor.
Yeah. And certainly from my point of view, it's not a factor. We routinely operate on women in their 70s.
Yeah.
Okay.
And I think sort of she's too embarrassed as well. I think that's what I was talking about.
Yeah.
Is if you do have the resources to find a surgeon that you feel comfortable talking with,
Yeah,
for sure.
then that will make a massive difference.
you need to be working with people where you don't feel embarrassed to ask anything. You need to feel comfortable with asking everything you want.
And I think you also, need to have the confidence that if they still try and discourage you, you can stand up for yourself and say, actually, I don't want to have that.
And I think,
absolutely.
and breast reconstruction was actively discouraged going back 20 years by breast surgeons who thought that women were being a bit frivolous about it. And certainly we've come a long way from then.
Yeah.
And the question at the bottom, which has come up in the chat box as well tonight, does having a reconstruction make it more difficult for early detection of tumours growing close to the chest wall?
No. So,
Glad you both said that.
Simple answer.
no, because if there is breast tissue left after a mastectomy, it's immediately beneath the skin. It's not on the pec muscle. So the usual place for recurrence is around the scar or on the skin, which is on top of the implant. Yeah.
Okay, so I think most of the others we've covered. If there's anything else that you wanted to mention, no, all good. So if we can click, you're in control of the mouse, Catherine. So I'd like to thank you all for coming on the webinar tonight, and thank you very much to the panel for all your great information, and Yvonne for your story, for sharing your personal story. It's not always easy. So as we've got up there, Council 13 11 20, if you've got any questions that come up for you tomorrow, please feel free to give that number a call. We have an online community that you can go into and chat and put blogs and get into groups, and that's available 24 hours a day. And again, as I mentioned earlier, if anything comes up for you tonight and you're feeling a bit distressed, please call Lifeline on 13 11 14. There's always someone there that can have a chat with you. Now we have an exit survey that will pop up. We'd please ask you if you could just spend a few moments completing it. It helps us with our future webinars that we know that we're getting things right. And that's about it. But a big thank you again, and good night to everybody.
Good night.
Thanks for logging on.